With any new therapy that you introduce, there are people, they are skeptic if the therapy is effective. This is the good nature of any academic environment, that the people out there, they're more skeptical than others, which makes a healthy mix of curiosity and researchers trying to find an answer to a question.
Because the group of children that we're talking about have trouble with their breathing, it's confronting, it's scary for parents, and it's scary for us too. I think that's where the initial scepticism about high flow was, because it wasn't well known and it was so different to what we were doing before.
One of the neonatal nurses approached me and showed me the high flow device they used in NICU. Initially, I was questioning how effective it was, and there was certainly a lack of any evidence. So there was a need for us to look into further research and quality and efficiency of the treatment. We saw a huge reduction in intubation rates, which decreased from 1/3 down to roughly 5% in our unit, which is a huge impact. The nurses started to use it more and more in infants with bronchiolitis. And over time, we started to realize that all of these children are less likely to require mechanical ventilation or CPAP.
I've been involved in research in the use of high flow in the non-paediatric intensive care setting. We found that there were no adverse events associated with that it could be used in a ward setting, and that in fact the length of stay was reduced when that occurred. So that has enabled us to feel a lot more confident in applying high flow in the emergency department setting.
From that, we saw a quick uptake of high flow use throughout regional centres and obviously throughout Australia as well.
I think we worried initially, before we were more comfortable with using it, that we might be delaying things for the patients. We needn't have worried about any of that. When the patient comes in, looking at their physiological parameters, within an hour or an hour and a half, you often know if that patient's responded.
In our own experience, with over 5,000 patients treated on high flow, we haven't yet observed increased incidence of pneumothoraces in babies being treated.
Some of the nursing staff were a little bit concerned about whether this therapy was perhaps too complex or that the children may be too unwell.
We were pleasantly surprised to see that with the right education and training of staff, that these babies were quite easily managed by the ward staff with a nurse-patient ratio of about 1:4 and achieve exactly the same successful outcomes that they did in intensive care.
If you're working in an emergency department and you want to consider using high flow, it has to be a very collaborative approach. You have to involve your intensive care and you have to involve your ward medical and nursing staff, because we don't work in isolation, and whatever therapy we adopt for the patient has to be able to be continued.
We find that nurses are feeling much more empowered to initiate the therapy as well in collaboration with their medical staff.
There was some initial discussion around the cost involved in introducing this, but what we found again is that the offset in terms of reduced length of stay and reduced intensive care admissions and reduced need for ventilation completely offsets any cost of the equipment and consumables.
It's been a fantastic change, so I would suggest to any other hospitals to embrace it. Provide detailed education, support your nursing staff, and they will feel quite empowered to be able to care for babies really well.
I strongly believe that high flow, it can be used very early in the disease process. It can be used in different settings like the emergency department, the pediatric department, or in the intensive care. I became from a skeptic to a convinced clinician who is using in daily practice high flow.